Thank you for joining us on today's webinar, Undercoded and Underpaid, making it easier to document to optimize reimbursement. My name is Nicole Douglas, and I'm a solutions specialist here at IMO. Before we get started, I'd like to take care of a few logistical notes. First off, this webinar is being recorded and will be available for future viewing. Throughout the session, all attendees will be in listen-only mode. So if you do have any questions, please go ahead and type them into the question section in your GoToWebinar console. Towards the end of this presentation, we will have a Q&A session and we'll do our best to answer as many questions as we can, but if for some reason yours is not addressed, we'll make sure to follow up with you after the webinar. So today I'm joined by two of our IMO rock stars, Dr. Deepak Pillai and June Bronert. Hello, both of you, and thank you for joining us. So Dr. Deepak Pillai is a physician informaticist here at IMO with a clinical background in adult neurology. He has a particular interest in provider workflow and efficiency, as well as problemless management. Mrs. Bronert is the Senior Director of Informatics here at IMO, where she provides health information management subject matter expertise both internally and externally for IMO's terminology solutions. June has held several positions throughout her career, including the Professional Practice Director at AHIMA, Coding Professional, Coding Supervisor, and Director at various facilities. So before we jump into our content, I'd like to share a little bit about IMO. I know we have a lot of revenue cycle and billing and coding friends on this call today, so you may be familiar with IMO. If you're unfamiliar with us, we specialize in clinical data enablement. And what that means is that we are the ubiquitous terminology provider in the US. We deliver terminology that is used in every major EHR and by almost 750,000 providers daily. And we extend that terminology foundation into normalization solutions to ensure that clinical data can be fit for purpose across the healthcare ecosystem. Our team of clinical terminologists maintains over 5 million clinical terms that are mapped to regulatory codes. And that helps clinicians capture clinical intent with a meaningful description while still satisfying the needs to capture regulatory codes like ICD-10 and SNOMED. This coding expertise extends into clinical workflow to make sure that physicians don't really have to think about coding. All they need to do is think and document clinically, leveraging the millions of terms that we provide in IMO, and let IMO do the work to tie to regulatory codes behind the scenes. That way, clinicians can capture the patient's story in language that's meaningful to them and build the structured data foundation for revenue cycle, population health, and analytics and quality reporting. It's truly a win-win. So as care delivery continues to advance and evolve towards value-based care, reimbursement models are increasingly data-driven. And as that data becomes more granular and incentives are tied to quality, the importance of solid clinical documentation is paramount. However, physicians just want to get through their day. And what's important to the clinician might be different than what's important for billing and coding. And when we speak to our clients across the country, it's really encouraging to see that cross-functional team members in revenue cycle, CDI, quality, and IT are all focused on making providers' lives as easy as possible by simplifying documentation so they can deliver the best care for their patients, because that's what it's all about here. And in today's healthcare ecosystem, data is the key to better patient management. It's the key to making sure that provider organizations are getting paid appropriately for the care that they deliver. And from our deep expertise in this space, we know that data quality is its strongest at the point of care. So in today's webinar, we're going to talk through some of the challenges that physicians face when trying to capture the patient's story in a structured way, and then what happens downstream when physicians are limited by the systems they use and how that translates into data used for billing. So with that, I'll pass it over to Dr. Pillai.
Great, thanks, Nicole. And hi, everyone. Thank you for your time this afternoon. As Nicole mentioned, that role, that intersection of clinical content and downstream uses, like for coding and billing and all sorts of other purposes, we'll touch on that in a moment, is the intersection where good interface terminology rests. And so I thought it was important to kind of give a foundational understanding of that, as well as my colleague June Bronert, who will also give a foundational understanding of the downstream impact of good codified terminology. And then we'll get into some examples as we walk through to demonstrate, to illustrate the role of interface terminology and the impact that specificity that can have. So with that said, and I give talks around the country. It's not EHR specific. It's on all sorts of different topics, be it specificity, problemless management, what have you. And I often get this comment, yeah, we have IMO, but what do you guys do exactly? And to that, I would answer with I think two words that you see on the left here: clinical terminology. In other words, in very simple terms, we provide dictionaries or terms or dictionaries that allow clinicians to say what they want to say clinically, not be beholden to standard or reference code sets like ICD or SNOMED, which certainly have their role, but as many of you know, often have huge gaps in their clinical coverage. And so we want to cover the full breadth of those standard terminologies as well as the clinical gaps, so that clinicians, adult providers can capture their clinical intent. And why that's important is illustrated by this graphic. And this is something I'm personally passionate about, which is that all of the nice functionality that EHRs can bring to the market and to their customers is that, whether it's decision support, order entry, regulatory reporting purposes, reimbursement and rev cycle needs, all of that functionality can be enhanced if you start with good content. The old adage, garbage in, garbage out. And where we play is making sure that that content is clean and accurate to enable and enhance all of those downstream functions. So that's a little bit, as Nicole introduced, a little bit about who we are. And what I just talked about is what we do at a foundational level and why it's important. And just a little look under the hood before we get into the details of this later on as we go through the rest of the talk, is a little bit about how we do it. And essentially, it's illustrated by this graphic here, and the vertical bar on the right represents the breadth of our clinical content. We've essentially created content that spans the full breadth of clinical of problems and diagnoses. I believe something on the order of 1.3 million terms, representing, as you can see on the slide, over 300,000 distinct clinical concepts. Expanding beyond the scope and filling in the gaps of SNOMED and ICD and so forth. And just to give you a kind of a clinical flavor of this graph, the size of those boxes is meant to be a representation of the granularity of our terms and the specificity of our terms. So in some cases, I know today we're going to be talking about the highly specific granular terms and the impact that can have. But to be honest with you, there are many clinical scenarios where sometimes less granular terms are needed. A patient presents themselves in the emergency department, gets sent home with a diagnosis of pneumonia. They're long gone before cultures come back, right? And so there are many scenarios where a causative organism is unknown. So there are many scenarios where a less specific term is clinically appropriate. An evolving stroke in an inpatient setting or in an acute care setting, for example. However, and what we'll talk about today is where we, at IMO, where we hang our hat are all those small boxes at the bottom, right? Those highly specific terms that cannot be captured by a single SNOMED or ICD code. Metastatic breast carcinoma with stage 3 metastatic breast carcinoma with estrogen receptor positive node. That means something to a clinician. And there is no way you can capture that with a single SNOMED or ICD code. We'll talk about another breast cancer example in a moment. But this specificity means something even to clinical communication. So with that, I'd like to turn it over to my colleague, June, to talk about why that's impactful from an introductory perspective.
Thank you, Dr. Pillai. Provider documentation is intended to capture the balance between the general presentation of a disease state and an individual patient's presentation of the disease state. This balance of common versus unique increases when multiple disease states manifest. Therefore, being able to capture the provider's clinical intention in an organized and efficient manner for each patient is vital. And a quote from the book Medicine in Denial states, as the Institute of Medicine, which is now the National Academy of Medicine, has observed, the problem-oriented medical record standard reflects an orderly process of problem solving, aids in identifying and resolving patient problems. So a key aspect of this process is documenting the patient's problems. And while this documentation supports various elements, we are going to focus on the impact to the revenue cycle. So as the term indicates, this is a cycle. And we'll start with healthcare services. Prior to a patient-provider interaction, the cycle begins with various pre-encounter processes such as registration and verification of any insurance information. In addition, any type of prior authorizations and required notifications, such as notices in support of the no surprise billing regulations, occur during this phase. The patient receives services, and then documentations of these services are captured. Next is code assignment. Charge information is posted to the account along with the associated charge master codes. All appropriate ICD-10-CM diagnosis codes are captured based upon review of the documentation. Procedure codes are also assigned based upon the received services and bill type. Moving to claims management, claim submission occurs. Return claim information processing, such as posting of payments and managing denied claims, is part of this portion. And then finally, looking at management and analytics for the overall program. This includes review of various revenue cycle management processes to identify opportunities for improvements. Defining and evaluating program measurements is also part of the overall program management activities. While there are many details involved with each one of these areas, we will look a little closer at the denials. And so there are many forms of denials, but regardless of the type, they present additional work efforts and result in either lost or delayed payments. Denials management involves investigation and resolution of why the claim was denied, and looking at the time sensitivity and managing that to ensure all investigations and resolutions occur within the stated timeframes from the payer, as well as tracking and coordination of denied claims is also another important element. And the process requires careful coordination and management in order to resolve denials timely. Denials can occur in multiple forms, such as, is the service considered medically necessary? Or does the service meet the appropriate level of care? Denials may also occur based upon coding rules and guidance, or the evaluation of a clinically validity of a diagnosis. We will look at this more in a bit, but regardless of the type of denial, it typically involves going back to providers for additional information. So it is important that the providers are able to document and reflect the patient's story. So the term clinical validation was introduced by CMS, or the Centers for Medicare and Medicaid Services, within a 2011 Recovery Auditor scope of work. And from a RAC statement of work, the clinical validation is a separate process which involves a clinical review of the case to see whether or not the patient truly possesses the conditions that were documented. Clinical indicators include items such as diagnostic test results, so for example, lab and imaging, along with the patient's physical indicators, potentially vital signs and other indications, and identified treatment plans. For example, if a septic patient is documented as having septic shock, but their documented physical indicators and treatment plans do not support the condition of shock, a review may determine that the documented septic shock diagnosis is not a clinically valid diagnosis. Another aspect of documentation is specification. Indicating the type of severity for asthma or heart failure are a couple of examples where the ICD-10-CM codes change based upon the documented information. Also, providing the specific stage of chronic kidney disease is another example of needing and requiring additional specificity. Regardless of validation or specification of a diagnosis, making the diagnosis capture process easier within providers' workflows to support their efforts to capture at the point of care and is working with physicians is key. valid and specific diagnoses support decreasing the various reasons for denials that we discussed earlier. Now it is time for our poll question. What is your most common method to improve diagnosis specificity and provider documentation? A, individual or one-on-one training. B, group training. C, asynchronous querying of providers. D, third-party clinical documentation solutions. E, incentives. Jordan, would you please launch the poll?
Yep, I just launched it, and we'll wait a few seconds to see what the overall answer is. All right, just a few more. It looks like 43% said individual one-on-one training. About 30% said group training.
Great, thank you.
Now we're passing it over to Deepak.
Great, thanks, folks. So yeah, let's walk through some examples now to illustrate some of the key points that June was making earlier, and I'll add a little bit of color from a front-end user perspective as well. I think these examples are generic enough where I think they span both inpatient and outpatient environments, care settings, where the broader message is around the role of specificity, which is important in both settings, or in either setting. Let's take this first example. And, you know, just from to add a little bit of perspective from a user end, is that in order to, I think one of the challenges that providers have when capturing specificity is that it's often cumbersome to do, right? We as an industry need to find ways to allow the capture of specificity to be easy, simple, and fast for providers. So take the situation of COVID-19 and immunocompromised patients. There should be easy ways to search for the term, find the term, and add it without having to go in multiple times, which you can see here on the lower right, where the presentation of it is not what's really important here. My main point is really it's important to with an easy to find expression, just by thinking clinically, to capture COVID-19 in the immunocompromised patient, capture the clinical expression and all of the codes that come with that term. And if you can make it easy and fast and providers can engage in it quickly, June will talk about some of the benefits on the back end that can provide.
Great, thank you, Dr. Pillai. And as you saw on the last slide, 2 ICD-10-CM codes are necessary to represent the clinical concept of COVID-19 and immunodeficiency. And keeping the search and select fast and streamlined, the opportunity of lost information is decreased. An incomplete patient story due to inefficient capture either generates a query or underrepresents the conditions. And so from the reimbursement perspective, the code D84.9 reflects HCC 47, which is disorders of immunity, as well as a complication or comorbid condition, or CC, from the MSDRG perspective. So now let's look a little closer on the next slide as to these elements. Reviewing the MSDRG potential, you can see that without the secondary code, a CC or MCC, which is the major complication or comorbid condition, is not present. This will result in a lower DRG assignment, such as DRG 179, while having the secondary diagnosis code captured changes the DRG to DRG 178, where a CC is indicated, and therefore a higher relative weight. The relative weight difference between the two DRGs is 0.3351. And if one uses an average base payment weight of $6,500, this difference could translate to an approximate reimbursement difference of $2,178. And on our next slide, we're going to look at the HCC impact. First, the CMS HCC examples, they do reflect potential differences in the risk adjustment factors. The examples make the following assumptions: that this is the CMS HCC model and is not another type of model. These factors represent community, non-dual aged continuing enrollees, and none of the following were calculated: the demographics, the frailty, the predictive ratio calculations, normalization factors, or coding adjustments. They do incorporate disease hierarchies, and the only changes to the patient information are the diagnostic conditions throughout the coverage year. And importantly, the annual expected expenditure has a direct result on the per member per month payment amount that providers receive. So as you can see here, the additional code provides a risk factor of 0.664 when it's captured, and this leads to an annual expected expenditure change of approximately $6,219. And now I'll turn it back to Dr. Pillai, who will review another example.
Thank you, June. And folks, just put that into a little bit of context, keep in mind that that example and the importance of specificity there is just for one condition on one patient. And so the specific dollar value is not what's important, but the directional impact that that can have across an entire panel of patients can be very, very significant for an organization. Okay, so let's build in some more complexity. We talked about a simple example and and the impact that that alone can have. But here's another example using breast carcinoma. Breast cancer metastasized to pelvis. Clinically, a fairly simple expression, if you will. And if you don't have interface terminology, clinical interface terminology, a provider on the front end has to use other terminology sets that are available to them, be it SNOMED, ICD, etc. So they try to use SNOMED, for example. There is no way that clinical expression can be captured by a single term, a single SNOMED term, right? It's actually, in this case, captured by three different expressions. One representing the primary malignancy, another term expressing describing the metastatic nature of the tumor, and then thirdly, another one expressing the anatomic site to which it has metastasized to. Similar story on the ICD end of things as well. There is no way a provider is going to go in three times. Most docs would do what I would do and say, I don't have time for this. I'm going to pick the closest best match and move on with my day. And oftentimes, that closest best match in this case is just breast cancer, losing all the specificity, let alone for clinical communication. But June will now talk about the impact that that can have from a reimbursement side.
Thank you. This slide shows the difference in code capture when a provider either captures their entire clinical intention or selects the closest match and moves on. So as you can see by selecting the closest match, that the malignant neoplasm of the breast and just the code C50.919 are captured and selected. However, being able to capture the entire clinical intention, there are multiple codes, 2 ICD-10-CM and 3 SNOMED, with the primary C50.919 and a secondary C79. So this just shows the difference in codes when capturing the clinical intention. And then how does that translate into potential reimbursement? If providers, again, select the best match and move on, then one code calculates a DRG without a CC and MCC. But as you can see on the right-hand side, a complication or comorbid is captured when the secondary diagnosis is appropriately reflected. And it does also reflect the patient's story of having a primary neoplasm and a secondary neoplasm. And the relative weight difference is 0.4415. And again, with our same average base payment weight of 6,500, this could translate to an approximate difference of 2,870. And so now turning our attention to the HCC aspect, you can see the different HCC categories along with their risk factors. And while their 2 codes are necessary to capture the patient's condition when fully specified, the disease hierarchies in the model are reflected here between those 2 conditions. And so therefore, there's really one HCC with the RAF scores, but you can notice there is a significant difference between the HCC 8 and the HCC 12 and those risk-adjusted scores. And so that score difference translates to approximately $23,000 or $498 in the annual expected expenditure. And so that is a rather large difference between the 2. And so now Dr. Pillai will talk about another example with specificity.
Thank you, June. So this is a slightly more complex example. And also, I think it's interesting, and we could almost have a separate webinar just on the role of a chronic problem list versus a encounter-specific list and how much specificity is valuable or useful for what purposes on either list. But let's just say for this purposes of this call, that and it's not uncommon, unfortunately, for better or for worse, not uncommon that on chronic problem lists, where that represent conditions across multiple encounters, that you might have, it's perhaps more common to see less specificity, and sometimes that's because specificity is encounter specific in certain situations. And so, if a provider is looking at this problem list on the top of the screen, and they're thinking, okay, I'm gonna address this patient's diabetes today. Clinically, that's a perfectly reasonable thought process, but as many of you know, that isn't good enough for from encounter-specific documentation perspective. In fact, it is a requirement to document much greater specificity. And diabetes, not only is it particularly complex in terms of the ICD pathways, but it's also very common of a condition that needs, and so I thought this was a good example for us to just illustrate and walk through. So while type 2 diabetes in and of itself is okay, perhaps okay for a chronic list, when I add it to today's encounter, I have to make sure, again, not looking at the lower right snapshot here, not worrying about the presentation layer so much, but to recognize that the full clinical expression, type 2 diabetes with renal disease on dialysis with long-term use of insulin is captured, along with all of the secondary codes. Then you have the right level of specificity to capture the right level of what's going on with this patient clinically. And that's important even beyond just an HCC, just from a ICD documentation perspective. And if you can do that, and you can do that in an easy way, we'll show you now how the impact that can have from a reimbursement perspective.
Thank you. So in this example, ICD is concerned about various clinical aspects of the patient's diabetes. What is the patient's diabetic type, type 1 or type 2? And for type 2 diabetes, documenting if the patient is on insulin or not does change the code assignment. And capturing diabetic complications are key. And depending on the type of complication, different elements are required. In this example, a kidney complication is present, so ICD wants to know the type. And the next slide shows the impact with and without the coding specificity. So as you can see, type 2 by itself, the code E119 with 1 SNOMED. So if there is not further refinement, then that remains the code with potential impacts of the HCC and the MDRGs. And we'll look closer at those here in a minute. But you can see with refinement that there are additional codes to represent all of the conditions that are captured. And with that, the DRG changes, and there's also HCC changes. So the increased specificity does make a difference. And continuing on looking at the DRG potentials, Even though both DRGs are without a CC or MCC, the actual overall assignment or grouping does change from an MSDRG of 639, diabetes without CC, MCC, to DRG 700 to reflect the kidney and or urinary tract diagnoses without CC, MCC. And so the relative weight difference is 0.1369, and the same average base payment weight of 6,500 is used, and to calculate an approximate difference of $890. Continuing to look at this through the HCC perspective of with and without the additional specificity. So the overall disease interaction hierarchy again comes into play for the HCCs 134 and 136. So therefore, only one of the factors is used in the overall calculation along the way. And the potential difference between the risk-adjusted factors of the HCC 19 diabetes without complications to the patient that has complications and those complications are coded is 0.633. And so that translates to an annual expected expenditure difference of close to $6,000 or $509.28. And so as you can see, there are differences between capturing the specificity and those secondary codes in multiple fashions through those examples that we have walked through. And now I would like to turn the presentation back to Nicole for some final thoughts regarding documentation.
All right. I'm back. Okay, thanks June and Dr. Pillai. So if I could quickly just recap a few things that you said. The first is that complete diagnosis capture benefits everyone. It benefits the physician for a number of reasons, from patient safety because appropriate detail is captured and then shared across encounters and providers. And because if it's done right at the point of care, they won't have to get a query to revisit documentation a day or a week or several weeks later to update just to make sure that's accurate for billing. It of course benefits the billing and coding teams because they have a rich source of documentation to build claims accurately. And as June showed, each coding miss can greatly impact reimbursement. So even missing a fraction of patients can mean a big impact on reimbursement annually. And of course, it benefits the whole organization because the data foundation created at the point of care supports billing, quality reporting, analytics, and population health management. And point of care diagnosis capture is key because that's when clinical information is its most accurate. But in order to make sure that happens, we need to make sure it's quick and easy to capture appropriate detail needed for ICD-10 in a way that isn't burdensome on providers. So underlying both of these points is that enhancing the overall EHR experience empowers downstream data quality, and usability is key to making this vision a reality. Physicians just want to get through their day, and we need to empower them with easy-to-use tools that are clinically meaningful so that they can capture data to the best of their ability. So much can get lost in translation between the patient visit and when a claim is built. And IMO can help make that burden easier on providers while satisfying the needs of the coding team to capture granular ICD-10 codes for billing. So with that, I'd like to open it up for Q&A. So as a reminder, if you have questions, please go ahead and type them into your GoToWebinar console. We've got a few here, so we'll go ahead and get started. So Dr. Pillai, this first question is for you. How does the specificity or content flow into the doctor's note?
Yeah, that's a great question. The short answer is it depends on the integration of the content into each EHR, right? If you take a step back from that question, whether it's a provider's note or any of these downstream functions that I mentioned early on in the talk, decision support, order entry, what have you, patient education materials, so forth, right? The integration of content and how it flows throughout an EHR is tailored for every EHR experience. I think the important thing is that making sure that that content is clean and specific for each of the use cases is the role that IMO can contribute to the overall EHR experience. And so to answer your, and so in particular to your question about the provider note, I've seen it in different ways. In some environments, I've seen that specificity being prompted to the provider right there in their note as they're creating their assessment and plan, or the assessment section, I should say. In other scenarios, I've seen it being prompted in a separate module, if you will, where for problems or visit encounter diagnoses, so that specificity then can flow throughout the EHR, not just into the provider note. So long answer, but essentially it depends on the integration in each environment. I've seen it in both ways.
Excellent, thank you. We've got another question here, Dr. Pillai. I think this one is for you as well. So we are implementing other vendor solutions to catch gaps in specificities that providers are not capturing in their documentation. So how does IMO terminology interact with those solutions?
Good question. You know, I think as an industry, there's clearly recognition that specificity matters. The reality is, again, as I mentioned at the beginning, it's hard to capture that in an easy way for front-end providers. That's fast and easy and efficient. And so as an industry, we've all kind of created all sorts of different solutions to help address that. A lot of times, as you mentioned, there are solutions to catch gaps when specificity has hit the note, or excuse me, conditions have hit the note without the specificity. There are a variety of solutions to capture that, or to come back to and find that specificity. I think philosophically, where IMO generally is, and where the role of interface terminology, I should answer it more broadly, is to capture that specificity further upstream, ideally at the moment of initial documentation. Then you can have, you know, I think you can tackle this problem of specificity from a variety of different angles, but if you capture it further upstream, then there are fewer gaps, fewer misses on the back end to be caught. So I think, broadly speaking, the approach can involve a variety of solutions, not just technology, but process and people as well.
Excellent, thank you for that. All right, we've got another question. June, I'll point this one at you just to make sure we're fair here. So based on what you showed today, does that mean IMO is able to pick all of the additional codes necessary on the description of the diagnosis or assessment? Or does the provider pick one by one from the list?
Oh, great question. Yes, based upon the diagnostic term that the provider selects, all of the appropriate codes can be provided with that automatically along the way. So for those examples of like COVID in the immunocompromised patient, when the provider selects that one clinical concept, all of those codes are associated to that diagnosis or the problem and available to be used downstream along the way.
Yeah, and the only thing I would add from a user perspective is it will be very difficult to otherwise expect a provider to go in multiple times and pick all the necessary codes in terms of compliance with that. So being able to do that automatically and efficiently is key, and is really central to the notion of interface terminology.
Great, thank you both. Okay, last question we have here is, can the information flow from a clinical note or lab values into coding? So through natural language processing or automated lab detection, how can we automate the generation of these codes?
This is June, and I will start. It's also a lot of great questions today coming in, and that they're improving the efficiency around the entire coding process has been a focus of the industry for a while. And I know that can be accomplished in a variety of ways for that, in capturing that information and to have codes presented available for the coding professionals' roles to turn into that auditing from those automated generations to ensure that all of the codes align to the coding guidelines and the documentation that is provided. So that has been continuing on in various ways and fashions. So the specifics as to how that may happen has been unique to organizations as they've been walking through those processes, but it is definitely areas of conversations that are important. So I would encourage you to check within your organization what conversations, if any, have occurred around the, utilizing the NLP and other elements to support a semi-automated process for the coding professionals.
All right, thank you very much. I think those were all the questions that we saw come through. So thank you all for joining us today. We hope you found this webinar helpful. You will receive an email from IMO with a recording of this webinar. If you have any additional questions or would like to schedule a demo, please send us an email at sales@imohealth.com. So thank you all and have a great rest of your day.